Today what we're going to hear about in this session is the ins and outs of allergic disease management with Sigrid Pitkin. For those joining us now for the primary care stream for the first time, my name's Claire Niverovich and I'm the Manager of Health Pathways at Western Victoria PHN, and I'm facilitating the stream today. What we'd like to do before we get started is just again thank our sponsors. We can't run these sessions without them, and a big thanks to the Epworth Hospital who is sponsoring this session for us today. I'd also like to just pop up here for you the links to health pathways that we have related to allergic disease management, and there's some great content on there for you. If anyone doesn't know about health pathways or would like to provide any thoughts or feedback, come and have a chat to me afterwards. It's a big focus for my team to get some really great resources on there for you. And what I'm going to do with the session today is we'll have Sigrid will do her presentation, and we'll then move to questions at the end of the session. So we'll come round with a microphone to those here in person, so please wait for the mic before speaking so everyone can hear. And we'll also go to online questions, so please type those in as you think of them, and you can vote for the ones that you want answered as well. So I'm going to introduce Sigrid to you all now. Sigrid's a nurse practitioner in the area of allergic diseases. She's able to diagnose, manage and treat patients for asthma, eczema, allergic, rhinitis and food allergies in both the paediatric and adult populations. Sigrid has a strong interest in research and rural health and is working with the National Allergy Centre for Excellence on their rural shared care model for allergy management. So Sigrid, over to you.
That's me. Okay, so after that brief introduction, I'm Sigrid. I work at Rural Allergy Group, which is a business that I set up myself. I work out at Ballarat, but also in Warrnambool, doing a bit of an outreach program out there. So today we're going to be reviewing the pathophysiology of allergic diseases, diagnostic tools that can be used in the general setting, but also what we do once you refer to us. Current treatment in primary care for children and teens and infants with allergic diseases, and I've got a few updates for you from the NACE and from ASCIA regarding GP management of allergic rhinitis. So first of all, I'm going to cover asthma. So just a bit of a review. Asthma is a common allergic disease present in children. It's very hard to diagnose in patients under 5 years, and that's because children under 5, as you know, have very immature airways. They're floppy. They're a lot smaller than adults in terms of proportionate sizing. So when they do have an infection or some sort of constriction, it does result in a wheeze. So often parents are like, they've got asthma, there's a wheeze there, but normally it's obviously viral induced. So we don't generally do a diagnosis in under 5s just because of those immature airways. It can also be caused by lots and lots of different things, which it can be quite hard to try and work out what those triggers might be. Sometimes people know exactly what it is, other times they don't. So some of the triggers could be pets, and that's not just pets in the home. Sometimes childcare centres or schools have rabbits or chickens or things, so you need to be a bit more mindful that it's not just what's in the home, that it's also in their environment. Grandma might have horses, or there might be a cow, you know, especially in the rural setting, they might run a cattle farm or have cows running on the paddock next door, those sort of things. Smoking, secondhand smoke. So if there's a parent who smokes or a family member that smokes, that's a big issue. Vaping is a similar issue with the chemicals and things that, what was that gentleman's name? Sandro spoke about this morning with the e-cigarettes as well. Bushfire smoke, we saw a lot of asthma flares when there were the bushfires in Gippsland, when all the smoke came through to Melbourne. That can often be a trigger, and that often tends to find a new round of diagnosis of asthma because that might be their only trigger, which obviously is not a common occurrence, hopefully. Pollens, that's a big one. Ryegrass being one of the major causes of the pollen trigger, but also things like the Melbourne University have a app called the Pollen app, where they measure the amounts of pollen in the air during the spring and summer, and they found that like 80% on the high pollen days, about 80% of the pollen in the air is actually cypress trees, not ryegrass. So ryegrass tends to be a bit of a main go-to culprit, but generally it can be other things that are not so prevalent, like the cypress, which make up a big percentage of it. Cold weather. So coming into this time of year, you're probably going to have to put people back on preventers and look at maybe possibly starting them. Cold air tends to be quite a big trigger for asthma, especially in young children. That's when you sort of get the presentation of, they tend to cough a lot at night. That's generally from the cold weather in the room. Dust and dust mites, they're also a very high cause. I think dust mite might be the actual biggest cause of asthma in children. And when you often tell a parent, yes, they're allergic to dust mite, they get a little bit offended. I can see it in their face. It's like, it doesn't matter how clean your house is, they're everywhere, they're in carpets, but there are ways you can reduce it by taking soft toys off the bed, no carpets in the bedrooms, limit the use of central heating, those sort of things. And thunderstorms. They obviously work in a different mechanism, and I'll go through a little bit more about thunderstorm asthma a little bit later in the presentation. So back to the pathophys, back to med school now, so a bit easier than what you would have done there though. So essentially asthma is when you've got a narrowing of the airway. So you can see that we've got, on the left here, we've got the normal airway where you've got normal membranes, not too mucousy, the muscles are nice and relaxed. At baseline with an asthmatic airway, you've got the middle one, where you can see that the lining of the airway is inflamed, which causes the ridges. And then the muscles are still relaxed just in baseline, but you can see that already at baseline their airways are compromised compared to the normal airway. So that when they do get triggered, the muscles, the smooth muscles around contract, there's good increased mucus secretion, and the airway becomes substantially smaller, which results in the difficulty breathing. So asthma is associated with the sensitisation of the airways to common allergens. We listed them before. Rapid airway narrowing is a result of IgE-dependent activation of airway mast cells. This in conjunction with the release of the rapidly acting histamine and tryptase pathways along the generated products of prostaglandin D2 and adenosine acting together to contract the airways, smooth muscle, to promote vascular leakage and stimulate mucus secretion. So it's generally always caused by an allergic trigger. So, as we said, inflammation of the airway, increased mucus secretion, constriction of airway muscles, and then you're in trouble. So symptoms of asthma in children and teens. So this can be one of these symptoms, or they can present all of them. So it's important to obviously do a thorough history when you're collecting, when there might be the suspicion of it. So coughing is one. Wheezing is the main one that people tend to associate with asthma, but it can, like I said before, it can just be a cough in the evening. That can be enough to be, I think you've got asthma. Shortness of breath and chest tightness. And obviously with children, particularly young children, it can be sometimes difficult for them to verbalise what's going on. and how they're feeling, especially in those younger years. They don't know how to say, oh, I'm short of breath, or my chest feels tight. So trying to, I think in this instance, in the under fives, it's important to go by the caregivers and say, is this normal for them? Have they been expressing anything different? Because they're the ones who know the child the best. So diagnosing asthma. So in children aged 1 to 5, well, all children really, needs to be a thorough assessment and medical history. As I said before, it's not commonly done in that age group because of the episodic respiratory symptoms such as wheezing and cough are very common in children, especially under 3. Getting a child under 5 to be able to perform spirometry reliably and repeatably is not really achievable. And a high proportion of children who respond to bronchodilator treatment don't go on to have asthma at school age. So that's why it's generally not diagnosed at that age. So yeah, I don't think I've ever seen anyone under 1 diagnosed with asthma. 1 to 5, there is some diagnoses, but generally only by specialists. Children 6 and above, the gold standard is spirometry. In children under 6, you can refer them to specialist hospitals like the RCH. I'm not sure what's available rurally, but they do have alternatives where they can sit them in a special machine and measure the different levels of oxygen and nitrogen and everything and work out what the gas exchange is. But of course that's quite complicated and a bit over the top for something like this. So just looking at some differential diagnosis. So what else could it be if you're sort of thinking, oh, maybe it's asthma, maybe it's not, or if someone keeps coming and presenting with one of these conditions, perhaps maybe it's actually asthma, it's not one of these. So bronchitis and bronchiolitis, RSV, whooping cough, because as you know, as children get older and their airways more mature, they don't have the hoop with the cough. So obviously in younger children you can pick it, or just immature airways, especially in kids who were previous prems, they can take a little bit longer to get that airway maturity. So you might find that they're a bit more prone to having some of the airway issues into primary school. And allergic rhinitis, they could have a postnasal drip that's causing them to cough all the time. So treatment of asthma, I'm not sure if you've seen this beautiful poster of all of the different types of medications. Generally, with children, you start with inhaled corticosteroid as a preventer, and then you might go up to a combination one, such as a seretide, which has a little bit of a reliever in it as well as the preventer. We do also have the non-steroidal preventer in the form of montelukast, which is a good alternative if you're finding that they're not getting the relief they need with the seretide, or the treatment regime you've got them on. Unfortunately, there is some quite nasty side effects with that medication, so it does need to be discussed and gone through a little bit more thoroughly than what you might with other medications with the family, just for them to look out for some warning signs. If you've got a child who is on an asthma preventer and then they're having Ventolin 3 or 4 times a day, first thing I'd be checking is, are they actually taking it, and are they taking it correctly? Those two things seem to be the biggest reasons why people are having problems with their asthma, particularly in children. Any of the inhalers should be given with a spacer. All of my patients, I'll give them a spacer, just because studies have found that if they have Ventolin or a preventer without the spacer, it just, I think something like only 4% or 5% of the medication gets into the lungs, whereas if they do it with a spacer, they've got a special static control that keeps it all airborne, so then they're getting like 85 or 86%. So that could be a massive difference in the treatment of their asthma. So that's preventers. Relievers, you've got your salbutamol and the like that obviously are for when they're starting to feel a bit wheezy, a bit tight in the chest. They can have that to relieve the symptoms. Again, strongly encourage the use of a spacer. Obviously, it's not always practical if they're going out for a run. You know, there's not really a pocket to put a spacer. But yeah, just generally when if they're using it at home or they've got a footy bag or something, then to put the spacer in there. Reducing exposure to allergens. So if they're allergic to cats and they've got a cat in the house and they constantly can't get their asthma under control, it might be worth rehoming the cat. Although the cat's probably not a good example because apparently cat hair stays in houses for up to 7 years after the cat has gone. So yeah, maybe a deep clean would be in the case as well. Yeah, time to move house and rip up the carpets and yeah, do everything. Allergen immunotherapy. If there's a known trigger, if they're only spring, summertime, that's the trigger, is when it's high pollen days. Allergen immunotherapy can be indicated for the help asthma symptoms. So when would you refer to a specialist or when would you keep managing yourself? So if they're under 6 with persistent symptoms of asthma, if they're over 6 where there's a suspicion of asthma but you don't have any spirometry available within your practice and nowhere to refer to do the spirometry. If a child or teen is not responding to treatment or when it's poorly controlled. Some good resources are Asthma Australia and the National Asthma Council of Australia. So you saw the poster that I put up before of the preventers and relievers. Often when people come to me, I was like, oh, you want a preventer? Yes, I am. Well, what's it called? Oh, it's the purple one. So it's handy sometimes to have that poster on the wall or nearby so that they can, tell you which one they're on. And National Asthma Council have lots of resources online for health professionals. Asthma Australia also has information for health professionals, but they're more targeted for patients and families, so they have a lot of resources for them. And asthma plans and that are on National Asthma Council. All right, so we'll move on to eczema. So just another brief overview of eczema. So it's a common condition in childhood mainly, with 36% of children under the age of 6 having had a diagnosis of eczema at some stage in their early childhood, which is a lot more than, when I was looking up the stats, I was like, oh, that's a lot more than I thought it would have been. But so it's quite prevalent. It's more common in younger children and infants, unless, a lot of children outgrow it into adulthood. And those sort of with more serious condition tend to carry it through to adulthood. Again, this can be caused by a number of different triggers, including the good old dust mite. So pretty much with all of the allergic diseases, dust mite is a bit of an enemy. Heat is a big one, especially coming into this time of year. You'll get the children coming into the clinic and they're rugged up to the nine and in artificial non-cotton clothing, and their little cheeks are red, and you've just got to tell the parents to strip them off. Don't put a heater in their bedroom at night, just keep cotton layers only. Heat is a real problem for people with eczema. Fragrance soaps and moisturisers and the like, shampoos, conditioners, bath bombs, all of those sort of things are often quite a big trigger as well. And that includes eczema-friendly moisturisers you can get from the chemist that have oatmeal and avocado oil and things like that. With eczema, there's been studies to show that if the first time a child is introduced to a food is through their skin, then they're something like 80% more likely to develop a food allergy to that food than if the first introduction was orally. So that's because of all of the immune cells that are in the skin at the time, with the eczema obviously flared because the skin's broken. So just be wary when patients are coming in saying, oh no, I'm using a really soothing oatmeal Moisturiser, you've just got to be like, no, and avocado oil, and I mean, they sell it well. It does sound lovely, but it's no good for people with eczema, unfortunately. A little bit of research has also gone into recently salicylates are a bit of a trigger for people with eczema. So it's relatively new research, so there's not a whole lot out about it at the moment, but they're basically in things like berries, cereals, curries, those sort of things, which it's not an issue in that you have to eliminate the food, but you just need to look at the accumulation in their diet of it. So if they're having avocado in the morning for breakfast, then blueberries for morning tea, and then a curry for lunch, and then it's like every meal they're having has salicylates, then I recommend trying to substitute some of them out because it can cause a bit of inflammation. And food allergies. Both IgE-mediated and non-IgE-mediated can cause issues and flares in eczema. So the pathophysiology of eczema. So there's defects in the filaggrin, transglutaminases, keratins and intercellular proteins that interrupt epidermal function. So by having that interruption in there, then children with eczema don't have the cholesterols to keep and the fats to help keep the skin intact. So you get the breaking of the skin, and then once you get the breaking of the skin, then you get irritants in, which causes the inflammation, and then you get the inflammation and the itch, and then they scratch, and then it's kind of like this cycle that just doesn't seem to get better. Like I said before, the impaired skin barrier has been considered the first step in the atopic march. So the atopic march is when children generally tend to start with eczema. Then they'll be exposed to a food through the skin. Sometimes it's not deliberately with a moisturiser. It could be that mum or dad's had some peanut butter and then they've kissed the child and they've had a bit of eczema on their cheek, and then they've been exposed to the food that way. Then they might develop a peanut allergy. Then they've got that allergic disease really brewing with the eczema and food allergy, and then it generally tends to progress to asthma and allergic rhinitis later in life. So the impaired, like I said before, leads to inflammation, increased risk of allergic sensitisation and infection. But like I said, that's the cycle. You get the inflammation, goes to itching, scratching damages the skin barrier even more. The irritants and allergens penetrate, you get more inflammation, more itching, more scratching, and it's if you can't break the cycle, it's really frustrating, and it can really impact the quality of life of not only the family but the patients too. There's actually several types of eczema. A lot of people just think there's just one, and so sometimes when people come and say, oh, I think I've got eczema, if it doesn't look like the typical one, which is atopic dermatitis, which is generally generalised rash, itching and cracking of the skin in mainly cuboidal fossa and popliteal fossa, sometimes, cheeks, it can be anywhere, but generally that's sort of the main presentation. Then they sort of think, oh no, that's not eczema, but there's actually quite a few different types. There's contact dermatitis, which is only in a specific spot. So this person's allergic to the metal that's on the wristwatch. So it's only in that one spot. Treatment is much the same, and maybe get a rubber banded watch or something that is not going to cause irritation. Dyshidrotic eczema. It's more common in adults, so we don't really see it that much in children, but just important to know that it's around. It's normally only on the hands and feet, and it's normally caused by exposure to chemicals. So cleaners, nurses, we get exposure to lots of chemicals on our hands when we're cleaning and things like that. Seborrheic dermatitis is only present where there's a large amount of sebaceous glands. So it's only mostly in the scalp. So for young babies, that's also known as cradle cap. So that's actually, cradle cap is a type of eczema. Hand eczema, as just on the hands. Again, most likely in adults with chemical exposure. We've got neurodermatitis, which also is similar to atopic eczema, but the main trigger for this one seems to be stress. So it might be a bit harder to try and work out what's causing it. Nummular eczema, which is also known as discoid eczema, appears in circle-like shapes like that. It's more common in patients who also have the atopic dermatitis. So they might have flares in the cubital fossa, and then they might have a few discoid eczema spots around the rest of the body. So symptoms of eczema. Eczema can differ between patients. However, most present with patches of reddening of the skin, hot skin, dry skin, itchy skin, and in uncontrolled eczema you can get weeping and excoriation. So in the diagrams you can see on the left we've got the picture of the healthy skin. So you can see right at the top you've got the epidermis, which is all intact, and underneath is the dermis, which is nice and thick and regular, and then underneath you've got all of the other types of cells. There's a little macrophage, and you've got all looking healthy and good. And then you can see on the right we've got the picture of the atopic dermatitis skin. So you can see where the epidermis is, which is about a quarter of the way down the screen, where there's a dark purple line. So all above that is dead skin and damaged skin. And you can see that while the epidermis is mostly intact, there's one breach there, and there's no, the dermis is just all over the shop. So there's no regulation for the laying of the skin, and that's where you can have those breaches where the allergens and irritants get in to disrupt the skin barrier. And infection as well. So diagnosing eczema. So obviously we need to examine the skin. History of presenting problem, just to make sure that it's not being caused by food allergies or something like that. Review of the symptoms and triggers. So differential diagnosis, what else could it be? It could be a viral rash, so caused by a virus. It could be ringworm. Sometimes ringworm looks a bit like the discoid eczema before. It could be scabies or herpes. So we've got to just keep in mind when we're looking at something like that, maybe it might be eczema, maybe it might be one of those conditions. So treatment of eczema. Moisturise, moisturise, moisturise. I don't think I can tell my patients enough that that is one of the best treatments for eczema, is to try and keep that skin barrier intact, and then that will help stop that cycle. It's simple, but with young children it's a pain because they're wiggling, they don't want it on, and often the good moisturisers that contain the lanolin leave an oily film on the skin, so it's not overly pleasant to have on when you're a bit younger. Only to use moisturisers in the pump pack or squeeze pack. I think most brands have moved away from the tubs, because if you've got a child with eczema, you're putting your hand in the tub, you're moisturising, and then you're going back every day. Things are growing in that tub, and then you're likely exposing them to infection. Only using sensitive washing machine powder. None of the fragranced Omos and all that needs to be just back to the basics with everything. No smelly soaps or moisturisers. Warm baths and showers only. We see a lot of teenage girls who run a bit cold, going and having boiling hot hot showers, and that it just is an absolute flare to their eczema. You've got to limit the temperature that they're in. It just needs to be warm, not hot. Obviously we've got the over-the-counter topical steroids, so they're just ones you can go into the pharmacy and say, I need a steroid, I've got a rash, can I have one please? Yep, they're pretty good for basic rashes, good for contact dermatitis. We've also got the prescription topical steroids. We've got the TCIs for the face, so the pacromolus, or tacromolus. Bleach baths are also really good, which whenever I tell parents, oh, you're doing bleach baths, I always picture like their face looks the look of horror on their face. And I picture the old people in the homes when they got caught doing those kerosene baths. It seems like it's really bad and really dangerous, but it's actually quite safe. You just use like a tiny little cup of household bleach with a 9-litre tub of water, warm water. You just measure out the bath once, and then you know, okay, I can fill it to that level, and then put it in. And what the bleach bath does is it's got bleach, it's got a bath oil, and it's got salt. You can do it plus or minus the salt. The salt is there for disinfectant reasons, but the bleach helps to clear the colonies of bacteria that are forming on the skin. So if they're having a really bad flare, it's really good to clear off the colonies to make sure that they don't get an infection. And there's a really good bleach bath recipe on the RCH website. So when would you refer? If the eczema is not well controlled, if you've prescribed Advantin fatty ointment and they've got the Elidel for the face and they're still getting frequent flares, maybe it needs to be time to start to look at what is actually causing the eczema here, or is it being applied correctly? If the eczema's been infected or is infected, then that can be sometimes a bit of maybe the family need a bit more education, or maybe they need a different treatment regime. If the triggers for eczema are not known. And these are some really good resources. Like I said, the RCH have a really good bleach bath recipe, and the Eczema Association of Australasia have a lot of good resources for families and health professionals. Okay, we will move on to allergic rhinitis. So just a brief overview of allergic rhinitis. So it's not so common in infants. It generally increases in incidence and severity as we age. The top 5 triggers of allergic rhinitis in children are ryegrass, dust mite, plantain weed, pets, and cypress. So the pathophysiology of allergic rhinitis is symptomatic disorder of the nose induced after exposure to allergens, so follows the same sort of pathway as asthma and eczema. Specific IgE antibodies build, resulting in symptoms such as sneezy, watery, itchy eyes, and sinus congestion. And like asthma, it can be just one thing. So people sometimes might wake up in the morning with swollen eyes, and they're like, "Oh, but I don't sneeze and I don't have congestion." It's just like you don't have to have that to have it. Depending on which allergen the patient is sensitised to, symptoms can be present at all times or only seasonally. So with dust mites, it's all year round. With the pollens, it's only seasonally. Symptoms can have a big impact on quality of life, school and work. There's a couple of pictures here that even when I'm out at the shopping centre, I can see kids with allergic shiners and I'm like, oh God, they've got really bad hay fever. So you can see they've just got these dark circles under their eyes, and they do have a little bit of a shine. And the transverse nasal crease, which is from kids who just do this all the time, they actually, over time, get a different shaped nose. So when kids come in looking like that, I'm like, yep, you've got a bit of rhinitis that's not well controlled. So this is just a basic picture of how it all works, but in the thinking of time, I'll move on from this slide. So the symptoms, we've got the sneezing, watery, itchy eyes, nasal and sinus congestion, coughing from postnasal drip, and at great risk of thunderstorm asthma. More so than asthmatics, because they don't, generally, if you don't have asthma, you don't carry around Ventolin. So what actually happens is you've got the whole pollen grains that are quite large. They get swept up into the cloud. As you know, there's differing pressures and differing temperatures up in the thunderstorm cloud. They actually break down the pollen particles to be tiny, so small that they aren't stopped in the nose. They go down into the lungs, and that's when you get asthma, thunderstorm asthma. So generally, when we had the incident a few years ago, I think it was 85% of the fatalities were not known asthmatics. It was all people with hay fever. So diagnosing, you need a history of symptoms, inspection of turbinates, skin prick test or blood test. We've got a normal turbinate on the left there, so when you're looking up with the otoscope, and you can see on the right, there's the enlarged turbinate. And what sometimes you can see in severe cases is when they're kissing, and that is when it might be indicated to put them on perhaps a short course of prednisolone to bring the swelling down, so then the nasal spray can get in there and do its job. Because if you gave a nasal spray to someone whose nasal turbinate is kissing their airway passage, it's not going to get to where it needs to, and they're not going to find any benefit from it. But also checking they don't have a deviated septum. So what else could it be? Common cold, flu, eye infection. What do we do to treat? We've got oral antihistamines, topical antihistamines, so nasal sprays, and topical corticosteroids, which are the nasal sprays as well, and the combination of the two. In severe cases, you can use montelukast for severe allergic rhinitis. Immunotherapy, main treatment for children over 5. Allergen immunotherapy, I'll just touch on this lightly, available in sublingual or subcut. Sublingual's taken every day, subcut's given monthly at the GP, initiated at the specialist. Duration in treatment's 3 to 5 years, so it's not a quick fix, it's a big commitment. Patients can expect seeing results after 3 to 4 months with sublingual and 12 months with subcut. And sublingual is more expensive and limited with the allergens available. With subcut, you can customise it to the patient's allergies. However, some children might not want to be using a needle. Mechanism of action is to slowly introduce the allergen to the patient's immune system. In small amounts over the course of the treatment, the patient's body learns that the allergen does no harm, and that's through the T cells, with the naive T cells not getting converted to develop the IgE. So when would you refer? If the patient's still symptomatic, on topical steroid sprays, if the patient's symptoms are affecting the quality of life, if the patient is missing school or kindergarten, daycare or work due to the symptoms, and if the cause is unknown, or if the patient would like to take immunotherapy. So some good resources there are ASCIA, that's the Australasian Society of Clinical Immunology and Allergy, and Allergy and Anaphylaxis Australia. I don't have time to go through food allergies, but just an update to give you, ASCIA is actually pushing for GPs to be able to initiate immunotherapy rather than having to refer to specialists and then us sending back, because it's been proven to show that it's quite safe, and obviously you're trained medical professionals, so just watch that space in terms of GPs being able to initiate immunotherapy. And there are a couple of pilot programs that are going to be getting up and going as a bit of an outreach program using telehealth and training up nurses in GP practices to perform skin prick testing and doing score ads for eczema and things like that. So if you've got a practice that is in a more rural setting, I guess, Geelong's probably not rural enough, but you know, if you've got your Warrnambool, Horsham, Bendigo, or Arachnabeal, anywhere that's sort of quite rural, and you've got a nurse that's willing and capable, and it's something that you want to do, then please reach out. That's it.
Thank you, Sigrid. That was very interesting. The cat hair 7-year thing's going to stay with me, I think. So we've got some time now to take some questions. We'll start with the room and then we'll go to our online ones. So I think we've got one up the front here. Just we'll bring the mic to you.
Hi, I'm Claudia. I'm a GP in Melbourne. I had 2 questions. One is, what do you have any recommendations for what's a sensitive, like, washing powder? Because, like you said, not the Omos, but they have like Omos sensitive. But
yes.
Is that, and I looked and I was like, I don't actually know what any of this is. And
So generally, you need to look at obviously the non-fragranced, and there are some brands, I think it might be Earth Care and QV are actually bringing out a range. there is some that you can get at the chemist as well. And obviously, you know, those sort of things are also influenced by families' ability to purchase those, because often the ones at the chemist are quite expensive, and for them, they can't afford a $12 tub of washing powder. They need to get the $2 one from the supermarket. So, but yes, there are a couple at the supermarket. Earth Care, I think, is one. But on the Eczema website that I put up, they do have some links for those sort of things.
And my second question was, with the bleach baths, you know, it's for infection, but you said it's for flare-ups that you can use it. So would that just be really bad? Would it have to be weeping, or if it's just...
So if they're needing to use a topical corticosteroid, that's considered a flare, and that's when they should use it. So then it'll stop progressing. If you wait until it's weeping and infected, then obviously the bacteria has already formed quite a colony there, and it will help, but it's kind of a little bit too late. So generally, if they come into you and you're like, oh yeah, you need some steroids, then I'd be like, I recommend you do this 3 times a week. And then if they've got an infection, it'd be like twice a day or once a day you're doing that. So you can cater, scale up or scale down the amount of baths that you're recommending on the severity of the flare. Yeah.
Yeah, thanks for this, Jeff, GP John. Just the difference between RAS blood testing and the skin prick testing. What's your commentary on that? Thanks.
So with food allergy, it tends to be quite accurate. Aeroallergens, it can be quite accurate too. I guess it comes down more to what the families want to do. Obviously, if it's something that's a little bit different, like I had a patient last week who their child had a reaction to oysters. I don't think there's a RAS test for oysters, so they would bring in the oyster and then we could do the skin prick testing. So especially for children, skin prick testing is a lot more gentle than having a blood test done. But in terms of accuracy, neither are 100%. The gold standard for foods is the food challenge. And for allergic rhinitis and everything else, it's the history combined with the blood results and the skin prick tests that will indicate the likelihood of that allergy.
Hi, thank you very much for your presentation, Sigrid. I'm a community health nurse in Melbourne. I just wanted to ask on the emphasis you made on oatmeal, because having lived the experience, like I actually suffer from eczema and asthma, so I have the double. Yeah. Jackpot. And the thing was, when I was in my teenage years, I was recommended to use the oatmeal by a GP. Yeah. So then that's where I go, okay, like it worked for a few weeks, and then my symptoms came back. Yeah. And then that's why I was wondering, like, would like to ask, what was that, effect, I guess, that had on, in terms of why it would have re-triggered, the symptoms and it. Yeah, so
you're unlikely as an adult to develop a food allergy as you are in childhood. Yeah. And on normal people's skin, oatmeal can be very soothing, and avocado oil can be very soothing, but it's just not recommended for eczema. And I think a lot of the moisturising companies have a lot to answer for with the way they market, because I've been into the chemist and I can see it. It's like eczema, soothing skin, and it's just like there's avocado oil in here, So people, they're trying to, I think it's about education and helping educate everyone onto what's suitable and what's not. And yeah, perhaps obviously dermatologists are good resources for that, as well as allergy specialists too. Yeah.
We'll take one more question from the room, and then we've got some online.
Yeah.
Hi, I'm a local GP. I'm just wondering what RAS tests you would do for somebody with hay fever, with potentially house dust mite allergy, but they're not 100% sure, so just looking at what other tests to put in your RAS screen. Yep,
so what I generally do is we'll ask a few questions. first question I ask is are the symptoms year-round, or are they seasonal, or are they both? So sometimes people can have a baseline hay fever, and then in the spring and summer it's worse, but then it's always there. So that would be, to me, I'm going to test for some pollens, but there's something that's there all the time. So either a pet in the home, dust mite, there could be a flowering plant in the house or something that could be causing that trigger. So I'll ask, especially like I'm based in Ballarat, there's a lot of beautiful old brick homes there which have a lot of mould issues. So, you know, do you have any mould in the bathroom? Is your house got damp issues in the winter time? Those sort of questions will lead me to be like, okay, maybe I need to test for moulds, maybe I need to test for dog, maybe I need to test for dust mite. And with the seasonal flares, then I'll test the eczema, the grasses, cypress, plantain weed, those sort of ones. Yep.
These are from our online participants. With the drive to reduce our carbon footprint, should we be prescribing more aerochamber style inhalers?
Yes, probably. And I think it's a good way to get on top of asthma, but I think sometimes when people come in, they just need to be given the best medication to get things under control, and then they can be switched at a later stage. It's unfortunately not up to us. It's up to the companies to produce more environmentally friendly medication to prescribe to the patients. Yeah, but good question.
Thank you. If a snotty 2-year-old is getting good relief from Zyrtec, is that likely to be allergic rhinitis in such a young kid?
Yep. I see lots of very young children who've got a sneeze on cue there. A lot of allergic rhinitis in young children, and generally they've got, they've got atopic allergic diseases, so they'll have the eczema as well, they'll have exposure. Generally mum and dad have got some sort of allergic disease as well. So yes, if they're responsive, if it's sort of an ongoing thing, not a cold, they haven't just started at childcare, there's lots of reasons why a young child would have a runny nose, but if you sort of think, no, it's been persistent for a while and they're responding to Zyrtec, then yes, I would definitely be starting to think about hay fever. Yep.
And there's just one more. Does immunotherapy work better in kids versus adults?
It's probably longer lasting in adults actually, because they're less likely to have any insults to their system that might undo the immunotherapy. I'm trying to work out how to word this correctly. So things that if you as a child go through immunotherapy, generally we say, yep, you're going to be good for life, but if you're a girl and you go and get pregnant, that can change your immune system and then you might become re-allergic to the things that you've had immunotherapy to. Or you might develop hay fever. And it can be things quite big like pregnancy, things like that, but it could be something like you get in a car accident or you've got a really stressful job and you get this high stress situation for a period of a month or two, and that can be enough to change your immune system that you might need to recommence immunotherapy. So generally, it's longer lasting in adults because they've had more of those life events, whereas children, when they get a bit older, they're more likely to go and have kids and have stressful events than older adults, but definitely worth it, especially coming into high school years. You don't want them missing out on too much school or daycare and those sort of things that could affect their future. Yep.
Thank you very much, Sigrid. A terrific presentation, I'm sure you agree.